Okay, thank you all for joining us on the July 2nd Addiction Toxicology Case Conference. This is brought to you from ACMT, the American College of Medical Toxicology, and the American Society of Addiction Medicine. I direct you to previous Addiction Toxicology Case Conference Series FAQs that we were able to develop with the Opioid Response Network and American Academy of Addiction Psychiatry funding. And I'm Tim Wiegand, Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center. My co-moderator is Dr. Gloria Bashevitz, Medical Director, Strong Recovery, Professor of Addiction Psychiatry at the University of Rochester Medical Center. Our panelists are Dr. Richard Dent, the Medical Director of the Chemical Services at Rochester Regional Health and Clinical Senior Instructor, Department of Family Medicine at the University of Rochester Medical Center in Rochester, New York. We also have Dr. Robert Horowitz joining us again. He's the Chief in the Division of Palliative Care. Georgia and Thomas Gosnell, Distinguished Professor of Palliative Care at the University of Rochester Medical Center in Rochester, New York. And Thomas St. John, he's a certified recovery peer advocate, peer counselor, guest expert. He is a peer advocate for Delphi Rise in Rochester, New York. And Dr. Ross Sullivan is the Director of Medical Toxicology and the Upstate University Hospital Director of the Upstate University Medicine Opioid Bridge Clinic and Medical Director of Helio Health in Rochester, New York. None of our speakers have any conflicts of interest to disclose. And I'm going to jump right into case one. It takes a village. So this is coordinating treatment for a 57-year-old patient who has head and neck cancer and a severe substance use disorder. 57-year-old male with a history of opioid and stimulant use disorder had been diagnosed with squamous cell carcinoma of the head and neck. He's had several surgeries. He's had a bilateral neck resection, a maxillectomy. He's undergone chemotherapy and radiation therapy, and he's been followed by oncology, pain medicine, palliative care medicine. He's on the medication for opioid use disorder through an outpatient addiction treatment program. He had a complicated course. As I mentioned, it included the bilateral neck resection and maxillectomy, and chemotherapy was with cisplatin and radiation treatments, and he had weekly engagements with that. After the surgery, he had tumor-positive margins in the bone and tumor that was positive in one lymph node and some other samples, the lacrimal duct and a couple of other samples. He is divorced, lives alone, but he does have family support. He has an ex-wife and several children in the area. They don't live with him, but they are supportive. He's a heavy smoker. While he has a history of intravenous drug use, he had been using intranasal cocaine and heroin for a few years until earlier in the year prior to the surgery when he sought treatment. His compliance with his medications for opioid use disorder, which is buprenorphine or buprenorphine naloxone, has been a concern, although he reports taking the buprenorphine naloxone 8/2 twice a day. He's recently been on weekly chemotherapy regimens, radiation therapy, and a vigorous schedule of hydration interspersed with the chemotherapy, along with lab monitoring and on-site assessment. His labs show persistent leukopenia, thrombocytopenia, and he has a fairly severe mucositis and lichen planus, the oropharynx and tongue. Now, jump back. So, at an oncology visit in May of 2021, he's noted to be dehydrated and he has severe mucositis. This past week, he has missed all of his fluid and hydration visits, but made it to radiation therapy. His oncologist is very concerned and sends him to the emergency department for evaluation, noting he has really had limited intake. He drinks Ensure and hasn't really been able to keep that down, drinking normally several cans a day, interspersed with some oatmeal and some other food, but really hasn't been able to take anything, including fluids. He's very dehydrated, has severe mucositis. He's got cartilage breakdown in the nasopharynx, and the oncologist had thought that this was probably due to intranasal substance use, and his pain is not controlled by the BMX topical solution, the numbing solution, and buprenorphine naloxone. films, acetaminophen, and a non-steroidal anti-inflammatory, which have been prescribed. So he's sent to the emergency department for possible G-tube placement, labs, hydration, and pain control. And in the emergency department, he has noted to have difficulties handling his secretions due to pain. He has numerous oral ulcers and lichen planus, and there's bleeding of his lips and mucosa. And there's post-surgical changes, literally holes in his palate, nasopharyngeal area, and erosion with poor healing. And he reports that there's been no Suboxone for a week because insurance didn't cover it. So he has been sniffing heroin for the pain. The prescription monitoring program, or the iStop in New York, shows that he picked up regular prescriptions for buprenorphine naloxone, including one for 8 days of 8/2, 3 times a day. It's recently been increased to 3 a day. 5 days prior to his ED visit, the ED presentation. There was a gap of about 10 days before that, but otherwise regular 7-day prescriptions going back intermittently 4 to 5 months. There was a hospitalization where he had a gap to when he'd been initially diagnosed, and then he'd entered a detox to start treatment for opioid use disorder and to stabilize to start treatment for his cancer, and then he had his initial surgeries. So he is in the ED and reports 7 days no buprenorphine to one provider, 3 days to another. Labs show leukopenia, white count 2.1, neutrophils 1.1. He's anemic, his hemoglobin's 9.1, his platelets are low at 77. BUN and creatinine are 8 and 0.68. His chemistry is not too remarkable. He does not have an anion gap. His glucose is normal. His tox screen from 3 weeks prior is available, which occurred in the middle of a buprenorphine prescription. So there actually are results for not just the standard tox screen, which indicates cocaine positive. I don't have the line here, but this is cocaine positive and confirmed. Opiates, THC, amphetamines, methamphetamine are negative. Fentanyl, which is not shown here, is positive as well. And these results is less than 25, less than 2, less than 5. Those are buprenorphine levels. There's really no buprenorphine. This ED/UDS pending bupen prior 3 weeks. The visit in the ED that day just was positive cocaine. Fentanyl is positive as well, and the bup levels are pending. And so my questions now for the panelists is, we've got a very complicated patient who has really serious comorbidities with the cancer and substance use disorder and other challenges. Initially diagnosed, how do you support this patient? You know, if he's initially coming to you, and you know, what steps do you take to try and make sure he's engaged and establish a really good treatment team? And I'll ask Dr. Dents, maybe you can begin.
Sure, thanks, Dr. Wiegand. Yeah, this client was in our clinic, and although I didn't see him on his first visit, I did see him shortly after a hospitalization, maybe 5 months ago. And when I had met him, he was walking in. He was very pale. He had 2 JP drains in his neck from recent surgery, and he was accompanied by his ex-wife and by a daughter who had flown up from Puerto Rico. English is a second language, but he speaks it fairly well. And it was an overwhelming visit. I mean, these are overwhelming visits because so much is going on. He's new to you, and you're trying to kind of play catch up. You know, I work in a drug treatment clinic. So in addition to seeing a physician for MAT or a provider, folks are also we want to engage them with either a peer recovery coach or a therapist. And back in February, we were still doing a lot of telemedicine work. I had him come in, but our engagement with him initially was poor, I would say. He was getting a phone call, an English-speaking phone call. He didn't have a smartphone. And that phone call was from his therapist, who he had never met face-to-face. So he never engaged with the therapist. And after he did come in, we did coordinate those visits and tried to get him a care manager, which we ultimately, had success in, but it took a long time to have happen. So there were a lot of challenges around treating him. He was staying on his ex-wife's couch, and at this time, his daughter was visiting from Puerto Rico, but she had to fly back the next day. So he had very minimal support. Interestingly, he wanted to come off of buprenorphine at that first visit, and was hoping to get back on full opioid agonists for pain. But he had a very severe addiction history, so we tried to get him to take medicines more frequently. I think that to your point about collaboration and compliance, he was needing to meet with oncology and radiology sometimes daily. And so even though he needed the inpatient level of care or detox, he was struggling balancing both his pain issues and also his need to engage with therapy. So I do think that ideally, in retrospect, care management and a very early case conference to discuss the order of operations in his care. Because as I think back to February, I would have preferred to, I think it probably would have been beneficial for this client to delay treatment for his cancer and get stable from a chemical dependency standpoint.
Yeah, those are really good. And I can't speak to, whether or not that would have been appropriate. I know it was fairly already progressed and aggressive, and he had the surgeries and started chemotherapy. There was the attempt to stabilize. Dr. Horowitz, from your perspective, your team is going to be consulted in the hospital during treatment if he's admitted, but in planning, trying to coordinate planning with somebody like this who's going to have very real pain. What is your perspective in trying to work with the outpatient addiction treatments and all those other providers? What is the role of pain palliative care, and how do you think that you can best support somebody in this situation?
Yeah, no, it's dizzying to contemplate. It's so incredibly complicated. I mean, he comes into this diagnosis with his burden of suffering and sorrows already, and now he's got this life-limiting cancer and surgery that is changing him functionally and symptomatically forever and shortening his life on top of things. So you want to talk about triggers, my goodness. And your previous slide, I think, Tim, or maybe two back, you mentioned the number of different folks involved, and you're saying that again right now. I mean, how do you coordinate that? This notion of it takes a village is right on, and yet this gentleman, gosh, he has to navigate the village himself in many ways out there in the world, at least when he's in the community. He has to get from point A to point B. Across the town. Right now, he's in a hospital where Dr. Dent is not, right? I share this notion of case management, of coordinating care. Your last slide, Tim, that mentioned pain/palliative care. I don't know, is he seeing a pain specialist or is he seeing a palliative care doc? And those are different, and yet there's certainly some overlap. Who manages what parts of him? How much should Dr. Dent oversee his buprenorphine or pain management? How much of that should be ours in palliative care or pain management or toxicology? These are questions that we can only answer, I think, by sitting down and talking together, Zoom or otherwise.
Yeah, you bring up some great points, and all of that, basically, the consult for our team, the toxicology addiction team, was to, help determine, first, should buprenorphine be restarted in this patient that really doesn't want to start buprenorphine. He prefers full agonists. And, that in and of itself gets to be problematic because now you're having a patient who's highly dependent on opioids who will have withdrawal treatment and craving that you need to treat with full agonists. And so running through my head right on the first phone call is, is this a hospice patient in palliative care really from that perspective? And, we need to talk with oncology and hematology and see what their perspective is. Are they going for a cure, or is this, the goal to really keep them comfortable instead of focus on the cure? And talking with him, he wanted to continue treatment. The insight regarding medication impacts, not staying on buprenorphine was really limited, as well as just simply the complications from the substance use. And so it really became challenging. Fortunately, we have a community. I know Dr. Dent well, and we were able to have some interactive collaborative discussions about and along with pain medicine on how to proceed, and we can talk a little bit about that.
Right, Tim, may I just real quick,
Oh, go ahead.
On that question, it does matter. There's a question here in chat about that. So prognosis, so if he came into this with a very light, short prognosis, that would change things some. It doesn't go away the reality of substance use disorder and all of its impact. It doesn't mean we should disregard it. But I think best I can tell from this case, and I'm not the expert on this, I mean, he has a good long while ahead. I think his median life expectancy is probably multiple years. And there was a potential, I think, for this to be treated for cure. So he has good reason to expect that he can get at least some good long while with additional symptoms related to the surgery and treatments.
Yes, absolutely right. So that is key. If this were a cancer aggressive, the lifespan potential for cure was nil. They're very different course, but this is a curable cancer, and he has years ahead of him, depending on his response and really how he's engaging, but also potential for lifespan and quality of life to be dramatically reduced if any number of things happen. There's things. Comments, questions coming into the Q&A, and Dr. Bashevitz, you're manning that. Do you have any first comment on this case from the beginning? And are there other audience questions?
Actually, there are no questions in the Q&A, but there are a few questions in the chat so far about, and one person is mentioning, is methadone an option for him? And I think it certainly would be an option for him if he's healthy enough otherwise to tolerate it. There's a lot of pros and cons to it, and maybe we'll get to more thoughts about that as we keep discussing the case.
Yeah, he did. When he did come to us on buprenorphine, and with past experience with buprenorphine around and possibly during a very long incarceration. The social challenges and the isolation of this patient really are barriers. And I think that, and then the mental health and the depression. So I think methadone is a great option. We had trouble getting him to reliably answer the phone and to arrive to appointments. So and I don't think he'd be a great candidate unless it truly was a hospice prognosis link, for oral for methadone tablets. So I think an OTP would be great and safe for him, but the challenges were really, really hard in coordinating care for this gentleman.
We did think about that, and I just trying to get to the appointments when he had challenges getting to so many appointments, and also there are limitations certainly around treating pain through an opiate treatment program. Not that he couldn't certainly work with a pain provider. In addition, the dosing for the methadone is for the dependence, not for pain, but that was discussed, and we'll talk a little bit about that as the case progresses. Dr. Sullivan, do you have any comments?
I think none other than what everyone's been saying. I'd like to learn a little bit more about his barriers with the buprenorphine, and specifically a little confusion on his part, and and just does it, did he use all of it within the first couple of days? Is he forgetting that he has it because he has so many medical appointments? Does it not work at all, so he doesn't take, so just some more questions specifically as to what's actually happening with the bupe, because we do know that bupe can work really well with pain as well. And maybe I agree methadone would help a lot too, but people who have sometimes head and neck cancers and airway issues and full agonists in a dependent patient can be maybe a little worrisome. So, just a few more, maybe more information on the patients, what's actually going on with the bupe, what are the barriers of taking it? Does it just not work, or really what's happening? Because we still may be able to optimize that, it's not necessarily totally out of yet.
For background, he did, he had trouble getting on it and showing stabilization. So we did have him come in for a directly observed therapy. We watched him take some doses. We did eventually get screens showing the levels there. And he actually was very happy with, he really looked better and was doing well, to your point, Dr. Sullivan, because he looked great on it. And Then we decided that I think he had a dental surgery or an oral surgery, jaw surgery, and maybe it was the biopsies, but he briefly needed a higher dose. But then he started to really unravel. I think he lost some social support. He started reporting prescriptions stolen on the bus, another prescription lost. And that's when things started to unravel shortly before he presented to Strong Memorial Hospital.
Ask TJ, you're a peer, certified peer, and this is a challenging patient, but describe the role that peer may play in this situation. What type of support options could you bring to the table?
So this is definitely a tricky case as walking into it as a peer, primarily because we're not doctors, right? And there's a lot of gray area in that aspect of how to approach a situation like this because of the barriers, right? This person's on chemo, he's on pain medication. Those are all different barriers to face treatment options. I think it's super important to walk in and support this client no matter what he's going through, right? Because there's such a stigma on substance use disorder. And when you throw in a life-crippling prognosis of cancer on top of it, sometimes people feel like their world's ending at that point. So to just be there and support them no matter what is the biggest thing. For me, I would definitely want to work with the doctors and the counselors and find the best treatment option for this person. It would more than likely have to be a hospital-based, just because of those barriers, and it could be an all-in-one kind of thing for this person. And if that's not something that, they were up for, there's many different things such as like intensive outpatient, there's just regular outpatient. I would surround them with, that's the biggest part, is I would surround them by love and make sure to tell them, that this isn't a death sentence,
I really appreciate your comments of just being there and listen to them. And my impression meeting in the hospital is, he was really depressed and he was disfigured from the surgery as well. And whether, that was a concern, there certainly wasn't a lot of support because of their family was there, but not, at his house, and his daughter went back to Puerto Rico. So this is a challenging patient, and COVID has really impacted some of the ability of peers to really go out to the homes. That's changing now, but some of the strengths of boots on the ground, seeing people in the community and where they're at with the peer counselors has been, transiently taken away. Let's move on. So in the ED, the patient's having pain and difficulty swallowing liquids. He gets fluids, intravenous fluids. They've been started with potassium. He's a little bit of low potassium. He's given dextrose and thiamine. And so what are the options for pain control in the emergency department? We have the buprenorphine screen from a couple weeks ago that shows no buprenorphine. He's reporting none for 3 days or 7 days. The consult initially was related to help with buprenorphine. Should we restart it? The patient is not wanting to restart it right now, and that obviously entails a discussion. But what would you do for pain control in the emergency department, Dr. Sullivan?
Yeah, being a ED doc, we're presented with these type of things quite a bit. I like, patients still have autonomy, and I think the ED doc academy would probably not go right with the buprenorphine right now, especially since he's been using heroin and maybe fentanyl as well. My two options would be probably a fast acting intravenous opioid. Head and neck cancers are incredibly painful. And, I would probably use some fentanyl in this patient under the acute circumstances. I also use intravenous ketamine a lot for pain in the emergency department. Sometimes in head and neck cancers, there's these theoretic, problems with secretions or, laryngospasms, normally at high doses that are pushed. So, but I would also not hesitate to use, 0.2 to 0.3 mg per kg ketamine in over 15 to 20 minutes if the patient was truly suffering with this intractable pain. So those would be my two options in the emergency department, or whatever your fast-acting opioid du jour is. But pain relief is as important as anything else in this patient, and maybe right now in the ED, buprenorphine is not the best time right here now to think about reintroducing this, especially in a patient that doesn't want it right now.
Tim, you're muted.
Yeah, thank you. Getting him comfortable was a priority. So your comment about fentanyl, pertinent fentanyl was administered intravenously. He had terrible mucositis and ulcerations and lichen planus and was bleeding, couldn't handle secretions. And so this was really just getting him comfortable and out of pain so we can have some discussion. So they did a very nice job of doing that, and also utilized some topical medication for controlling the pain and some of the particularly irritated areas, and the fluids and hydration, some dextrose, I think, helped him as well. And he was able to get some rest, and then agreed to restarting the buprenorphine. He wanted to wait for 16 hours, but we had a discussion about not doing a traditional washout and letting him be uncomfortable without using full agonists, and talk a little bit about how that was done. Patient is given parenteral fentanyl in the ED to good effect. Wants to wait until after the G-tube is placed to try and restart buprenorphine and naloxone at least 16 hours after the last heroin, which is earlier in the day prior to the oncology visit. Indicates he's using 6 to 8 bags of heroin and cocaine a day, all intranasal. And he says he traded his buprenorphine films for heroin and cocaine. And this past week, the cocaine use was higher for pain. He says he's using it for pain, and it helps with the ulcers. In this context, he's also really struggled making appointments for hydration and other follow-up, except for radiation therapy. My question is, what are your concerns about cocaine use in particular in this patient, and how might it impact his treatment and healing as compared to just simply, opioids? What does cocaine bring to the table? Dan, do you have any thoughts on that?
Yeah, I think obviously the ulcerations that he can get from cocaine, the poor healing, and then if these ulcerations, impaired absorption of buprenorphine and how it's used. So,
yeah, I think that cocaine, there's a lot of reasons. I think, first of all, he has head and neck cancer. So, using an intranasal drug like cocaine that causes, septal perforations is probably not a good idea. Its vasoconstriction systemically as well probably will inhibit any healing that he might need. Not to mention a lot of cocaine in our area has something called levamisole in it, which is a antihelminthic used, which has been associated with like skin necrosis and, wounds and healing problems. So probably lots of reasons why cocaine is not a great drug of choice in someone with multiple healing wounds and mucositis and sores from his cancer and other medications.
Yeah, those are great comments. Thank you, Dr. Sullivan. Any comments in the Q&A or chat, Dr. Bashevitz?
Sorry. Yeah, I also wanted to say that his desire for cocaine will spur more of the selling of Suboxone that is going on. So that will just make things worse. There is a question in the chat that's more for Dr. Horowitz, I think. And the idea here is, if he qualifies for hospice, could his pain be controlled with a morphine PCA? What are the pros and cons of using that versus something else in a controlled setting?
You could. There's so many competing interests here in a way. So, yeah, if our goal, like what Dr. Sullivan was saying, all of us got to get the pain under control, and the temptation to exhaust all non-opioid options is strong, particularly in somebody who's first line in his medical history is going to say something about heroin addiction. So people are very cautious. But putting that aside at least a little bit and talking about treating suffering, mitigating misery, yeah, a PCA is a very appropriate treatment. The challenge for him right now is he doesn't qualify for hospice. When he's sick enough, when he's approaching end of life, then yeah, in a supervised setting with caution, that could be a very appropriate thing to do. He could be home with a PCA potentially if he has arrangements. He could be in another setting with a PCA. We're able to accommodate that many times. The structural challenges for him, though, are really substantial. So to do that in a way that's going to be safe for him, safe for the community, safe for the provider, are going to be logistically complicated and possible.
Those are great comments. Thank you, Dr. Horowitz. I just have a slide that talks about some of the particular effects of cocaine. Cocaine is a vasoconstrictor. It obviously will impair wound healing. And so the oncologist's astute observation that the edges of his, some of the wounds in the nasopharynx were affected is likely from the cocaine. And Dr. Sullivan mentioned levamisole. Levamisole is a immunosuppressant drug. It was historically used to treat certain autoimmune disorders, but due to risk of adverse effects like neutropenia, granulocytosis, and certain types of vasculitis, it was taken off treatment options for humans. It is used as an antiparasitic and a common adulterant of cocaine. Anywhere to 70 to 80% of the world's cocaine has levamisole, and about 10 to 20% of the cocaine. It's a bulky white powder. So pretty much you're not going to get cocaine without levamisole almost anywhere in the world. And that, in addition to the vasoconstriction, neutropenia, agranulocytosis, vasculitis, leukoencephalopathy, cerebral demyelination. There's a reference, on the review and risk assessment of levamisole adulteration of cocaine. Not to mention the mood lability and interruption of treatment engagement, and then the diversion. And this gentleman, had been trading and selling the buprenorphine for cocaine and opioids. So a lot of other problems. The patient's admitted and toxicology addiction consulted and recommends coordination with outpatient provider, pain medicine, oncology, and the patient agrees to a buprenorphine microinduction, which really, after discussion with everyone, we determined that this patient will need full agonists, to treat his pain. He also needs treatment of withdrawal and stabilization, and to best do that, we thought that getting him on subcutaneous buprenorphine so that he's not taking it, doesn't have the option to not take it or trade it if he's in a difficult situation, mood, or craving, would be ideal. The first part, though, was to simply just restart the buprenorphine, and that was while full agonists were continued. He had the fentanyl switched to hydromorphone, and he had an elixir of oxycodone, 20 to 30 milligrams every 4 hours. And he was really kept comfortable with the opioid regimen and some non-opioid agents. So we talked a little bit about this as methadone an option being OTP. What about the outpatient strategy to help keep this patient stable? And I did mention subcutaneous buprenorphine. Dr. Dentz, do you want to comment on your thoughts and how you could try and keep patient? You already have, but any further comments on trying to keep them stable?
I think that using Sublocade for someone who's diverting is obviously the right thing to do. I mean, we know that buprenorphine in small doses, like let's say he was on 24 milligrams, we know that taking it many times throughout the day seems to help better with pain, but it's contraindicated in this guy because he's just unable to use it correctly. So the question I think is when do you say, he's saying, no, when, not just him, but any patient who says, no, I love the films work for me, let me get back on them, trust me, it will work. When do you say, this isn't safe for you, this isn't the right care, I'm telling you that the only way to get buprenorphine is Sublocade? And I think that his instance was was one of them where we really didn't feel like he could manage his buprenorphine as an outpatient. So I think that using Sublocade, and if he was going to go on full agonist as suggested in some of the comments, that I think he would just need structure and support to make sure he's not misusing them. So in other words, it wouldn't be like a script of 180 and saying, 1 to 2 tabs every 4 to 6 hours. It would be probably weekly scripts of agonists with maybe even pill counts or someone to make sure he's accountable and can manage the script. Otherwise, he will likely, even with the Sublocade on board, he would be likely to sell them all or use them all too quick and then be back on cocaine and something else to continue his run. So I think structure, support, but no longer the option of sublingual buprenorphine in this case.
Yeah, thank you. We had the discussion with him that the buprenorphine did not take out the option to treat pain that was not controlled with the buprenorphine, and that also a lot of his pain was withdrawal related, in addition, exacerbating the very real pain that he had, making it worse. It was up and down because of withdrawal and no stabilization, and then the cocaine. So eventually he did agree to the subcutaneous injection, which is not on formulary at the hospital, but it is available for outpatients. But there's some heroic efforts from multiple individuals were able to get it for this patient. But he undergoes a microinduction after discussing, and there's some discussion between the two of us. And we had a topiramate, 50 milligrams twice a day, which is an off-label use for cocaine craving. He initially had declined the subcutaneous buprenorphine, then agrees after discussion, and then also pain medicine really played a role in feeling their position was we're very uncomfortable in prescribing opioids for this with the active fentanyl use and non-compliance with the buprenorphine, and the risk the treatment has been interrupted and without taking medication. So coordination for the subcutaneous buprenorphine for the inpatient setting was done. He's titrated up to 4 milligrams of half of an 8 milligram 4 times a day. At one point, he reports the films are intolerable for his mouth sores, and he's refusing to take them. So about 48 hours where we didn't realize that he was actually refusing them. Nursing was documenting, but really hadn't made a lot of comments about missing them. And we realized, wait a minute, it's been almost 2 days. We need to get them back on. But he really said that the film was exacerbating his mucositis and ulcers. At that point, we had stopped the parenteral opioids because the symptoms had improved with restarting the buprenorphine. Now with the pain, he's in complaining of he doesn't want to take the film. So is there any tricks of your trade to try and get him to tolerate the film, to at least get him to the injection? We're within a couple of days here. Dr. Sullivan, do you have any thoughts?
Yeah, I think overall, just this is a tough one. If the patient really wants to get on this, it might be a good baseline for him to have this buprenorphine. If he's fully on board, I try to supplement as much buprenorphine as possible to make the person comfortable. Any adjuncts as well to the days preceding. But if he's already restarted on it, if we've already kind of microinducted him and we're starting to, get him on a sublingual, as you said, I just want to make sure that he's a good level of comfortability before we give him a shot with some good positive reinforcement, and let him know that this intramuscular, subcutaneous buprenorphine will just be maybe a baseline. It won't be the only thing that we do. I think that's important. Let him know that, there will be other things that we will try to do at the same time during it to continue to help him with this pain.
Dr. Horowitz, do you have any thoughts?
It's just a little bit. I mean, there's a fair amount of acreage in the mouth. I honestly don't have a lot of experience with Suboxone exacerbating mouth pain. I know it can for some folks and cause some tongue burning and such, and he might have a lot of mucositis. He probably has some mucous membranes that work. And not that this is very palatable to most patients. It can be given, and some some people out there in the world use it rectally. I think that's a hard sell in the hospital. I'm not recommending, he probably would have said, sure, let me add it. But it's a reasonable way of delivering if our goal is really to get the drug in the system in a way that might not hurt as much.
That's very interesting. I had not thought of that. There are some simple things. Sometimes when I've seen 4 milligrams ordered, it's 2 milligram films, so much greater amount than a half of an 8 milligram film. And using some topical local anesthetic potentially. In his case, he wasn't aware that you could actually take it buccally, so we were able to give him it buccally. There was areas of the inner cheek that he didn't have as much irritation, so we're able to get him back on that. And I just have our order set. This is a Epic e-record order set. When we recommend the buprenorphine microinduction in the hospital setting, we use 150 micrograms starting every 6 hours. And this is while somebody is continuing the full agonist. In him, it was initially fentanyl and then the hydromorphone and oxycodone. So 150 micrograms every 6 hours times 4 doses. The day 2 is 300 micrograms every 6 hours for 4 doses. Day 3 is 1 milligram every 6 hours times 4 doses. Day 4 is 2 milligrams every 6 hours, 4 doses. Day 5 is you're on your maintenance dose, and then you can continue the full agonist if there's pain, usually about 2 times to 3 times the standard dose. He was already on those doses. And the buprenorphine is really at the bottom for dependence, withdrawal, and pain management, and then the top is another opioid, which can be continued if it's the ongoing pain, or if really it was for withdrawal and buprenorphine sufficient, can be just basically stopped. This kind of is a schematic of titrating up, just a little bit different protocol, but adjunctive medications can be used, but this having done this many times in our hospital setting, we have not seen a patient have any precipitated withdrawal with that. So we have him take it buccally. He has less irritation, and we also changed to twice a day instead of 4 times a day. But within a day, the subcutaneous buprenorphine arrives, and we administer it in the hospital. In the interim, he had undergone G-tube placement and nutrition consult. Treatment. Outpatient was on board with following and giving the monthly shot and helping coordinate, work with his family. There had been not brought into the hospital, but at least contact via phone. Some topical local anesthetic prior to the buccal films, and then we'd given him the shot prior to leaving the hospital to get that in, then really left it up to pain medicine to determine in oncology to determine if he needed additional pain medications on top of the buprenorphine. And he was doing pretty good overall. And we'll move on to the second case, as this is an evolving case. But just in general, any other final thoughts on support as this patient moved from the inpatient to outpatient setting? He will have ongoing chemotherapy, radiation, and he has many medical visits. He lives alone, although at discharge, his ex-wife was willing to come and help do some cooking. And again, as happened earlier in the years, his children, some of them are willing to check and help, but he's really going to be primarily the primary one responsible for making his care. He had pain. If a patient is pain that's not adequately treated with acetaminophen, nonsteroidal BMX, and subcutaneous and buprenorphine, where he talked about what options. In general, Dr. Horowitz, Dr. Dent, how would you coordinate, the opioid therapy in somebody like this if you felt they really did need opioids on top of subcutaneous buprenorphine? Dr. Dent.
We're going to need. I'm sorry. We're going to need to be in touch, Scott. You and I guess, right? And help coordinate. Go ahead, say.
Right. We'd have to coordinate. We can't really take the pain on in an Oasis, a drug treatment clinic, and start writing full agonist. But we'd have to coordinate with you. And what I'd really want to do is, as I said earlier, develop that structure for this gentleman. My fear is, and I'm not sure if it's him or someone who's very similar to him in our clinic, but I think he might have eventually left his wife's couch and found a place that was a rooming house where there was active drug use in the city. So his landing spot is not good, and I think that having full agonists on him is going to be really risky, and I just think he'll need a lot of support. I would love to have him have gone bed to bed to a nursing facility who are reticent to take people with substance abuse history and on buprenorphine, but I think he would have done better there. So I just think he's going to need a lot of support early on and structure so that he knows that he needs to kind of stay on course.
And just to say, there are times when we have to say that agonist therapy, that opiates are simply not going to be safe. They're going to be off of the regimen, for your safety, for our safety, for community safety, and it's a sad reality. And yet I think it's an essential thing to say kindly, compassionately, to not abandon our care in saying that. Can we deny him pain medication? We can say that opioid are not safe in you, and evidence has shown that, and we can try it again, and we can try, and I don't know how many strikes is out. It used to be 1 strike you're out, then 3 strikes you're out. So I think we do what we can. We try to coordinate, and
I've tried again and so when someone says, the question, can you deny him? Sometimes we'll say, listen, when you're living in this boarding house, we've tried this 3 times before, and you've showed that it has not worked. We want to be safety. We really care about you. We care about your pain. Sometimes a happy medium is, can we get a supportive living situation? Can we get, whether it's recovery housing or medical housing, can we get somewhere where we feel like there's custody of those meds and we can safely write them? That may be a halfway point.
In this case, I've had a very interesting discussion about it. In addiction medicine, you have a continuum of disease as you do for other diseases. And when you have a severe disease, at some point you have treatment that is palliative. And my colleague had referred to palliative addiction care, which is interesting. I think that would bring a lot of emotions to surface, just simply even using that terminology. And we don't really have a lot of good options compared to other countries, and potentially wouldn't even call it that in other countries. If other options were available, they might be considered in Canada or Europe, heroin-assisted treatments, other options that you could potentially offer. But this is a challenging case, and as a Les checked, he did follow up with his appointments. He had some other medications. Someone prescribed gabapentin, which I was a little concerned about, because if he does come off of the subcutaneous buprenorphine, that it goes back to fentanyl use, that will increase his risk of overdose. But hopefully he continues with that, and with good coordination of care and support, we will see case to be continued. Let's move on to our second case. This is every time I get a prescription, it triggers me. Balancing harm reduction strategies for a patient with severe opioid and stimulant use disorder repeatedly requests restarting buprenorphine films from a detox setting. 41-year-old male with over 20 years of opioid use disorder and severe stimulant use disorder, cocaine, presents to detox setting 3 days after filling an 84-film prescription for 8 milligrams or 8/2, 3 times a day for buprenorphine naloxone. He's been exhausted, up for days with prolonged cocaine binge and fentanyl to come down. His arms have recent wounds, some open areas, no obvious cellulitis, but there's severe stigmata of IV drug use in his arms, neck, and axilla, and his right lower extremity. He has a past history of IV drug use, associated infective endocarditis, several other serious opioid-related infections, bacteremia, complicated abscess requiring surgery and prolonged antibiotics, hepatitis C, a partial nephrectomy, and several overdoses resulting in hospitalization. He's had over 30 detoxification episodes in the last 2 years at several locations. And after stopping treatment with numerous brief encounters with numerous providers, programs in the area, he engages with a local harm reduction clinic that he primarily sees for medications for opioid use disorder and the adjunctive meds, gabapentin, quetiapine, and bupropion. Working with a harm reduction program that is routinely given 2 weeks at first, then 4 weeks via telehealth for the last 4 months, he's entered detox program within 7 days of the 28-day prescription. Each time he gets one for the last 4 to 6 when it's given within 4 to 6 weeks time period. So at least 4 times. There's a couple of 2-week prescriptions in there, is why it's not monthly. A urine screen at each visit is negative for bup, positive for fentanyl, cocaine, methamphetamine, THC. Tramadol was there, not always, but most of them had tramadol and benzodiazepines. He's given diazepam as part of the detox regimen. Doesn't use street benzodiazepines, but the diazepam persisted. He's refused methadone eval and subcutaneous buprenorphine, despite saying, and this is coming from his mouth when he enters detox, every time I get a prescription for it, all I see is cocaine and what I can trade for. And he's asking me to be restarted on buprenorphine films, brand name, and for follow the same program he's going to as soon as he sees a counselor at the detox. My question is, discuss harm reduction strategies in general and how to apply to this patient in this situation. There's a wide practice variation in terms of offering medication for opioid use disorder. And Dr. Dent, can you maybe comment on working with a patient like this? What would you do?
Sure. Yeah, I think, and I'd be very interested to hear what other people have to say, what TJ you have to say. I think it's challenging because this is person-centered care. You want to do, we really want to have the patient help drive it, but you really have left, I would argue, have left harm reduction when you have consistent negative bupe and you're giving 84 films and they've already told you that they're craving cocaine. So you clearly are causing harm, but that doesn't mean you have to force them into methadone or the buprenorphine injectable, even though we think many of us likely agree that's a better idea. I think a halfway point again would be very frequent visits. And if it's I think people forget, even if it's monthly via this harm reduction clinic, they forget that they could have done 21 films with 3 refills. I mean, that's an option that might not cause as much of a risk, but I wouldn't be doing that in this instance because this person needs more surveillance. So I think trying to come up with a safe alternative, definitely confirming onboarding with directly observed therapy and confirming metabolites in the urine and then going from there. But again, it's kind of about, I think, finding that balance between a very paternalistic approach and prescriptive approach, but also not wanting to abandon them and wanting to, quote unquote, meet them where they're at, but also provide safe care. So very, very, very tight scripts, confirm they're on, and then have a plan B that could include buprenorphine subcutaneous if that didn't work.
Yeah, I mean, and I've had discussions with providers that feel getting more buprenorphine out into the community, whether it's diverted or not, is a harm reduction strategy in general. I think there's much better ways of getting buprenorphine out through education and increasing prescriber support, availability, incentives from payers. But for this patient, it was clearly harming him. I mean, he would get some, have a binge, and the money that he gets from 84 films and the extraordinary use really puts his health at risk. For him, it seemed that this is a risk and certainly not beneficial. He briefly comes in, stabilizes, reps up, and he's right back. And this is a cycle. Dr. Sullivan, do you have thoughts?
Yeah, I think that everyone's saying some great things. Sometimes people that require 24, this is just very, very anecdotal. They say they need the bupe, but they know they'll sell it. And in some patients that need 24 milligrams, I'll use 2 12 milligram films rather than 3 8 milligram films. And it seems that, at least anecdotally, maybe the dozen or 2 patients I've done this in, they all seem to use a higher proportion of their own films and give them away. Because they don't have like that extra 8 they give, and they kind of need a little bit more from that second 12. So I've done that in patients that, like this guy, like I really need that, but I can't help but sell it. And sometimes I've tried the 2 12s. Doesn't always work, but it's worked a couple times. And, and I think a general look into his other medications, you might get into this later, but, I understand the harm reductionist approach, but, things like bupropion and in certain cocaine users worsens their cocaine abuse. Some, maybe it helps it. In others, it might harm it. Same thing with gabapentin and quetiapine. These together might help them maybe sleep or help with anxiety. But there does come a point where it does sometimes maybe cause more harm sometimes. So, I'd look into those as well, and maybe some specific strategies like some film dosing modifications to see if it can help.
And certainly appropriate medications. What is the gabapentin indicated for? There was no neuropathy. Quetiapine is often used to come down from stimulant use. It combined with cocaine, sometimes referred to as a cue ball. Bupropion and referred to as poor man's cocaine, often when other intoxicants aren't available. We've in the inpatient setting, detox, crushing the sustained release, extended release. There's cases of injection use, risk of seizure, serotonin syndrome, toxicity with bupropion is really high. Those are concerning meds, kind of red flags in him. In this patient, the addiction provider covering had been working with them intermittently over the last 10 years, and there was a counselor assistant or peer that was key in establishing rapport. And after quoting him, reading him his quotes, every time I see this has got to be done a different way. If you're thinking of getting sober. So, TJ, can you comment a little bit on what peer could bring to this to help with maybe motivation to change or support in a patient like this?
Yeah, absolutely. So this would definitely be one of those situations where motivational interviewing comes in handy, and asking open-ended questions, trying to get them to solve this for themselves, right? I think this would be a really good spot if I was sitting with somebody and I would share some personal experiences with them, because I could tell you this client sounds like myself when I was in active addiction. And it's been proven that one alcoholic or one addict helping another seems to work better than others, right? So just digging a little bit deeper with them would be probably my best bet, right? Like asking questions like, what haven't we tried, right? You seem to have tried all this other stuff. What haven't we tried, And then, or ask questions like, I've seen you do this a few times, what trips you up, right? Try and get them to figure it out for themselves would be like the go-to route for me.
Those are great comments. Thank you. I'm not going to dwell on this next question. It goes back to the idea of microinduction, and we've covered this in prior webinars. It's in the era of fentanyl and fentanyl adulterated heroin, where we have this depot of fentanyl sitting in individuals. They're terrified in the detox setting or any setting, and restarting buprenorphine if they haven't been taking it for a while. And in this setting, the formulations that are used in the hospital aren't available, and working with patients outpatient, I'm highly motivated when I can have them cut the 2 milligram films to mimic the protocol we have for microinduction. But maybe Dr. Sullivan can briefly comment on how do you get somebody onto buprenorphine, when normally they're saying, I got to wait 72 hours, and you just have such a high risk of leaving AMA and the detox setting.
Me personally, I still use the COW score, and if a COW score is 12 or greater, and if someone's positive for fentanyl, I'm waiting maybe 12 to 24 hours later. I do try to use some adjuncts. Of course, he's on a few, maybe some of the adjuncts. But I try not to do real slow with the bupe, not necessarily. I'll give somebody maybe 2 or 4 testos, but rapidly increase them maybe right in that setting. We do it in the ER quite a bit for people who have been off of fentanyl for 12 to 24 hours. If their COW is 12 or greater, we're going to give them bupe and rapidly escalate it to make them feel better, even if there is some residual withdrawal, or even if there is some mild precipitated withdrawal. I'll treat it with more buprenorphine, as quickly as possible to make the person comfortable.
Yeah, that's the key, is giving a dose, and then if there's some precipitated withdrawal, rapidly titrating up. We've got just a few more minutes, and so I just want to kind of summarize this case. The patient has previously tried Topamax, topiramate for cocaine craving, not really working with compliance, and asking for baclofen. Is there evidence that baclofen works for cocaine craving? There was some historical data that showed it may have an effect. The GABAergic drugs indirectly dampening down dopamine, but the bigger trials have really, from my interpretation, there's minimal effect with baclofen. We already talked about what support peers can have for this patient in this setting, and thank you, Thomas, for commenting on that. The patient agrees to the follow-up in the outpatient setting. He's given subcutaneous buprenorphine. Although right between doing the consent and ordering the buprenorphine, he's ready to get back on the films, although very brief. Prescriptions are sent 2 to 3 days, observed doses using telehealth, doxy.me. The topiramate is increased. He struggles to keep appointments with counselors, but does come on site for the subcutaneous injection. 1 week after the shot, he says, I can't believe I didn't do this sooner. This has changed my life. I didn't have any stuff to trade or sell. I'm not using cocaine. He reports because staying with his mother outside the city, he's confident he can stay sober and just get years ago. 2 days later, he calls by 4 or 5 times. By 10 in the morning, he's irritable. He says, this shot doesn't work at all. I'm sick. I don't want to get this anymore. I need the films. I have to take something or it isn't going to work. I feel like I'm not taking something. I need a prescription. So he just held the course and reminded him that he's got buprenorphine in and that it looked to actually, he said the Topamax isn't working. And we looked to Disulfiram for cocaine craving. So just a little bit on Disulfiram. Disulfiram is an off-label indication for cocaine. For alcohol, it inhibits aldehyde dehydrogenase that causes a reaction. That's not the same effect it has in terms of the cocaine craving. It inhibits dopamine beta hydroxylase. There's excess dopamine and reduced norepinephrine. And this is thought to reduce dopamine-associated craving and reward. And there's research that shows that it affects craving, relapse rates, use, independent on reduction of alcohol intake. Less alcohol, less potential to move to cocaine. I have a slide on topiramate and the effect on glutamate and GABAergic systems leading to reduced dopamine levels and reward for anyone interested in looking at that. This patient reports getting through the craving. 2 days later, he's fine. He was in the middle of a really bad craving. And he reports that the Disulfiram is really working much better. He's missing a lot of appointments with everyone but the provider for the subcutaneous buprenorphine, but has gone 2 to 3 months with some cocaine use intermittently in the last week. But month 4 to 5 of getting the subcutaneous buprenorphine, he's still continuing buprenorphine, no fentanyl, no opioid use. And then the last 2 months, there was no cocaine. And he says that Disulfiram, he's not a drinker, so he doesn't have to worry about the reaction, but he's sober and keeping his appointments. We're at 2 o'clock. I know that we went through this case fairly quickly. Are there any last comments, Dr. Dentz, regarding this? We can maybe explore off-label medication use for cocaine craving in some future sessions.
Yeah, no, I think these are all great ideas for this client, and glad we were able to get them over to Sublocade.
Dr. Bishevitz, do you have any comments? And he went through this one quickly, but any key Q&A?
Well, there weren't too many on the Q&A on this, but my comment would be that it may take a village, but the people in the village should talk to each other, because I think there a lot more coordination would have been helpful. And I wonder if there was much conversation at all between the harm reduction facility and the detox facility until someone knew the person. And that was fortuitous, but it should occur as a more regular type of thing. It's very hard to do, though, in our current system.
It is, and he had specifically agreed to consent and then very quickly would revoke it within his visits in the past. So there were some barriers from the patient driving that, and it gets to some longer discussion about what ethically you're able to do if he's at risk for harm. It should have been obvious, though, from the providers seeing the detox prescriptions within 2 or 3 days of prescribing the month, which showed up on iStop as well. So the program would have obviously seen that he was going into detox within a few days. So why it was continued and not done differently, I don't know. It's interesting discussion. Dr. Sullivan, do you have any final comments or?
No, nothing further. Just highlights that there's great challenges in treating cocaine, but there, maybe different strokes for different folks. But it's it's good to see that continually us as a group of providers trying to find solutions for these patients.
TJ, thank you for joining us. Do you have any final comments?
No, the only thing I would add to it takes a village is, after getting the patient stabilized with chemo and all that other stuff, it'd be maybe suggested to turn it over to a peer to help the peer find this person more resources within the community. You guys talked about how he was in a tough situation living wise, and that's something that a peer could help them with, is maybe find something that's more best fit for them, so on and so forth.
Yeah, thank you. There's a lot of community resources sometimes that people aren't aware of. And so I'd like to end with a final thought. Dr. Horowitz, you're waiting for this one. And this is a final thought from Julius Caesar. And I chose this passage because reading, it's not just one of my favorites, but apartheid activist Sonny Vancreth was imprisoned on Robben Island in 1972 for involvement in anti-apartheid activism. Island prisoners were permitted one book, and he requested Shakespeare's complete works, and it circulated among fellow inmates who initialed and dated their favorite passages. This book is now known as Robben Island Bible, and it so happens that Nelson Mandela, who was also in prison for his anti-apartheid activism, selected this passage and initialed it M, December 1st, 1977. And the final thought is, cowards die many times before their death. The valiant taste of death but once. Of all the wonders that I have yet heard, it seems to me most strange that men should fear, seeing that death, a necessary end, will come when it will come. And this is from Julius Caesar, Act 2, Scene 2, William Shakespeare. Thank you all for joining, and please join us in August, the first Friday of August, which is August 6th. And you can check out the ACMT website for the FAQs and recorded sessions. These sessions are also available with the slides on the American Society of Addiction Medicine website. Both American College of MedTox and American Society of Addiction Medicine have the Addiction Toxicology case conference recorded and the slides available. Please complete any evaluations and suggestions for future topics. And I want to thank you all for attending, and please